We are recording.
Welcome, welcome, everybody. We are kicking off Black Breastfeeding Week here with Patients Are Waiting in the Diversifying Doula Initiative. I'm telling you, it's on. Black Breastfeeding Week started yesterday. I saw all kinds of social media posts, all kinds of amazing things, and today is the first weekday. So Patients Are Waiting in the Diversifying Doula Initiative said, you know what, we are going to hit the ground running, really putting a strong focus on something that is so important, and that is feeding your family, feeding your soul, feeding your family. So Patients Are Waiting is a nonprofit organization dedicated to eliminating health disparities by increasing diversity in medicine. We do have 3 areas of focus. 1, to increase the pipeline of minority clinicians. 2, make that pipeline less leaky. And 3, supporting minority clinicians in practice. That is what we're doing today. We are supporting Black and Brown doulas, midwives, IBCLCs, Cheryl Burks. She is going to introduce herself. She is part of our Patients Are Waiting DDI family, and we are excited for her to share her masterpiece, which is her knowledge of breastfeeding. And why is breastfeeding in the Black community and the Brown community important? Because it addresses so many other things. In addition to addressing the disparities that exist, we know the CDC just recently put out a report that says about 80% of white patients who are discharged from the hospital breastfeed, whereas about 59.8% of Black patients are breastfeeding at the time of discharge from the hospital. That disparity is important to note and to address. And that's why we're here today, to really fix those numbers so that those who are interested in breastfeeding have access to do so safely and comfortably. So I am excited to have one of the nation's few IBCLCs here with Patients Are Waiting tonight. And I'm going to yield the floor to her because she has so much more to say about this than I do. Cheryl Burks, we want to thank you for being here. And please go ahead and introduce yourself.
Hi, thank you. Thank you for having me. Thank you for that introduction. My name is Cheryl Burks. I'm a registered nurse for the past 20 years, and I've been an IBCLC International Board Certified Lactation Consultant for the past 7 years. I'm also working on becoming a women's health nurse practitioner as well as a postpartum doula. I'm a founder of Breastfeeding Black Babies, and I just started also passionate about maternity LC as well to expand my services to the Black and Brown communities. I'm here to talk about breastfeeding, why it's important. August is National Breastfeeding Month, and the last week is Breastfeeding Black Week. As Dr. Livingston mentioned, Black women are disparity as far as when we start breastfeeding and the duration of breastfeeding. The numbers had changed over the years where we are starting to breastfeed in the hospital, but we go do a 3-month or 6 months survey and see how long breastfeeding is going. We see that numbers has dropped tremendously. Moms has say either they get home and they didn't have help, or they get home and they felt pain, or they didn't have milk, all the reasons that they felt like they couldn't prolong breastfeeding. So we wanted to talk more about that today to how we can support those moms.
Yeah. Wow. Thanks, Cheryl, for being with us. We do want to stimulate and drive the conversation. So Sabrina has a few questions for you, and I know you are going to address some myths and debunk all kinds of strange theories that are out there. So Sabrina, why don't you have at it?
All right. Well, thank you again, Cheryl, for joining us tonight. So let's kick it off with what are the major benefits of breastfeeding that you see not only just for mom, but also for baby too, and especially Black babies. Oftentimes we hear these morbidities and comorbidities that Black babies have compared to their white counterparts, asthma, obesity, and all these things. So can you address some of those benefits that we see in breastfeeding babies?
Yeah, so breast milk benefit mom and baby. On the mom side, it can help decrease postpartum bleeding. So one of the hormones that's involved with breast milk is oxytocin. So that's our body natural hormone. And when we breastfeed, it's going to contract our uterus, which can control postpartum bleeding. So we'll have decreased postpartum hemorrhaging. It also decreased certain cancers like ovarian cancers as well for the mom. It also decreased postpartum depression. Again, that hormone oxytocin, that love hormone, it's another function of it. It helps calm a mom during stressful situations. So that can also help decrease things like that. Baby, yes, you mentioned asthma, also GI symptoms like diarrhea, less vomiting in those babies who's breastfed. So you'll see fewer pediatric sick visits if a breastfed mom is breastfeeding.
And do you often see these, even if it's only a short-term time that the baby is breastfed, say less than 6 months compared to more than 6 months or even a year?
Yeah, even the smallest amount of breast milk provides lots of antibodies. Okay, so no matter what duration, it's going to provide coverage for that baby. Now, of course, the longer you do it, the longer and more support you have for that mom and baby.
Right.
Wow. I like that you threw postpartum hemorrhage in there, since postpartum hemorrhage is actually the #1 cause for maternal morbidity and mortality in the first week postpartum. I think it's not lost upon this group and those who will be listening as we share this video. It's not lost upon us that Black women are 3 to 4 times more likely to die in childbirth, and we know most of those deaths occur postpartum. So if we can figure out ways to address or minimize morbidity immediately in the immediate postpartum period, like immediate skin to skin and getting that baby on, like you said, to help latch, it does help the uterus contract. So it's something that we can do in the immediate setting after birth. One, to help with bonding with mom and baby, but also to help to minimize any morbidity that may be associated with bleeding.
Yeah. And a lot of this education starts prenatally. So it's really important that these moms who are pregnant around 20 weeks or so, 24, 20 weeks or so, start getting that prenatal lactation education. A lot of moms don't know that a lot of insurance do cover for lactation services. So they don't got to come out of pocket with these services. So starting that education on kind of get them target, okay, let me see. Maybe buy into why breastfeeding is important. Let me buy into what to do once I have the baby. Because a lot of times when they are undecided, when they have that baby in the delivery room, they may just start bottle feeding because they're undecided. And, but if you kind of talk to them early on, talking about the benefits and talking about what to expect, what's going to happen right afterwards, how to position, how to latch, they are more likely to initiate breastfeeding. And then that continued support once they go home, they'll have longer durations of breastfeeding. And so insurance also cover postpartum lactation services as well.
Wow.
Awesome. And since we're on the topic of doing your homework and stuff, as a pregnant mama when deciding to breastfeed, what are some questions you recommend moms to ask an IBCLC or even like a breastfeeding specialist when they're inquiring about if this is really for them?
Well, the benefits, they can ask, what is the benefits of breastfeeding? If they're unsure, they can start out with that. How is breastfeeding going to help me? How is breastfeeding going to help my baby? Where to start? How do I go about learning how to breastfeed? Because it's not as simple as you put the baby in a boob. There are a lot of challenges that people come across: flat nipples, inverted nipples, tubular shape, different shaped breasts, breast surgery. So moms may have some predisposed risk factors that lactation consultant can walk through with that mom about.
You know what? For those who are watching, Cheryl, what is an IBCLC?
IBCLC stands for International Board Certified Lactation Consultant. So we are specialized in breast milk and helping breastfeeding families.
Awesome. And how can pregnant mama get in touch with an IBCLC? Do they reach out to their hospital that they're delivering at, or um,
So there's a lot of private lactation consultants out there, not more white than black, but there are a lot of private lactation consultants. There are also lactation consultants in the hospital. The difference between, and I work in the hospital as well, the difference between the hospital and private is the hospital lactation consultant is seeing everybody on that floor who's had a baby and who wants to breastfeed. So her time is limited. She's, it may be just one person on, it may be two lactation specialists on, but their time is limited in that realm. Babies may not always be ready to feed because of sleepiness or, a lot of issues that can happen right afterwards. But having that private one-to-one lactation consultant in the home or in the office space after, you have more time to really assess a breastfeed, to really see how baby's transferring, how the baby's latching, assessing whether or not the baby have any oral problems that can maybe cause pain with latching, and developing a feeding plan so the mom can know what to do to kind of get through breastfeeding to reach her goals.
all right, thank you for that. And when it comes to breastfeeding itself, is it always supposed to hurt, or like if it does hurt, is it temporary? Can you kind of go into that?
Yeah, so that's one of those myths. Breastfeeding is supposed to hurt. Breastfeeding should not hurt, right? It's a feeling that we'll feel. We'll feel the pulling, we'll feel the tugging, but it should not be painful or pinchiness. If the baby is latching really shallow, I actually have a little muffet thing to show you. If the baby is latching really on a nipple, this is the baby. Can you guys see my little muffet? Okay. If the baby is latching on a nipple, mommy is really sore, but not only that, baby doesn't get a lot of milk that way. If I was to just put this through here, these are the milk glands, right? And it's going all across the breast. But in the center, if the baby just latching on just on that nipple, it's not only does mommy get really sore, baby get a small fraction of that milk. So if baby is latching really deep, nipple and areola, baby's getting more milk, mommy's feeling less pain. So a lot of times when I hear that myth, baby's latching and I know it's supposed to hurt, I say, well, no, not really. Let's take a look at it. And then once we fix the latch, get baby on deeper, mom immediately feel a difference. And she said, oh, I thought it was supposed to hurt. And you really shouldn't feel pain. You should feel the tugging, the emotions of it, but it should not be like, oh my God, this hurt me. Right? Because then we're going to have sore, it can have redness to our nipples. So we can start getting cracked and bleeding nipples. And that's not normal.
Okay. Well, since we kind of addressed one of those myths, I have a couple of myths here. So another myth I have is that you can't breastfeed if you're sick.
So you can breastfeed if you're sick. Your body, your hormones, your breast milk makes antibodies to protect your baby and yourself from being sick. So those actually, your antibodies start working really more in abundance because you're sick. So it's helping fight off that infection.
Well, I know
Most
even as
medication.
as an OBGYN doctor, that question, and Dr. Hamlin can corroborate this, as a fellow OBGYN physician, when we were practicing during COVID, everybody was like, I have COVID, I shouldn't breastfeed because, my baby is right here and I'm breathing on them with this, terrible infection. And we're like, actually, no, breastfeed, go ahead and breastfeed because you are passing along those antibodies through milk and helping build the baby's immune system. So it's and again, that strengthening and bonding during COVID and, any type of relationship strengthening that can occur during that time was helpful as well. We initially thought it was good to separate moms and babies if mom had an active COVID infection, and we learned quickly, and even the data corroborated that babies who were breastfed with mom, at the same time, mom either had an infection or was recovering from an infection, had more robust antibodies in their bloodstream. So it was, you know, the science actually proved that as well. So.
Yep. Yep. And going along with the illness, moms think they can't breastfeed if they're on certain medications as well. And I was
Ooh.
going to say that's another myth. There are very few medications that a mom cannot breastfeed on. There's certain apps or websites that can collaborate with that, like Infant Risk Center is one of them. Dr. Hale's Medications and Mother's Milk is another one, that if a mom taking a medication, she can look it up and see if it's safe for breastfeeding. And again, there's very few that's not compatible with breast milk.
I'm sorry, can you list those again so I can put them in our chat so we can share them?
Yep. Infant Risk Center and Dr. Hale's Medications and Mother's Milk. LactMed is another one. It's LACTMED. Yeah. Oh, I see you finish that. Yeah, it's another one.
I just have a quick question in regards to this. I have oftentimes mothers ask, like, if they're on birth control, does that affect breastfeeding as well? Like, what kind of birth control they're taking?
Yes. Especially the double shot. That has more studies showing that it can dry up the breast milk. If that's the only alternative, of course, breast milk is going to outweigh. So we just make sure she's following a lactation specialist to make sure she's not dipping in her supply. Maybe she got to do some extra pumping on top of the breastfeeding to make sure she's stimulating more.
I just wanted to add, as I have my 5-year-old who was breastfed for 14 or 18 months, I don't remember now, and I had to give it up when he started eating oxtail. But for the you know, I think one of the things, and I love that you said, it's like this discussion really starts long before. So I think it's, as we're working on working to support families, is one, that while you're pregnant, having a lot of conversations that kind of help the person to understand, well, what do you want to do? You know, and if you're committed to breastfeeding, then you help them to know what are the reasons why. It might be like, I just think it's a good idea. But then when you bolster it with all this extra information of like all of these benefits, both for the mom and for the baby, and then you get like kind of some family co-signing on board, that's really helpful. And then I think from the medication standpoint, a lot of people, you know, they get pregnant, they just stop any medication that they're on. And that's like, please don't do that, you know? So when you're pregnant, you're working with whoever's prescribing your medications. And most of the time people say, nope, you're pregnant, I don't want to touch you, I don't want to deal with you. And then you're left with your OBGYN or your family doctor, or your midwife, whoever's taking care of you during your pregnancy, to kind of go through the medications, you know, the pros, the cons, what evidence is there out there about any risk to baby while you're pregnant. And then also, like, there's medications that we don't use in pregnancy that we can safely use in breast milk and breastfeeding. So it's like the most restrictive time would be pregnancy. And there's a lot of medications that people would opt to stop taking that they don't actually have to. But it's like you do this, all of it is in partnership with the patient and their care provider. And so I feel like it's just one of those things, again, where when I think about where we are for Black maternal health, so much of it is really respecting Black people, period, to say, we can have these conversations and we can to make decisions that are good for us. And it's like, present the information. Let's have a dialogue, you know, instead of just kind of blanketly saying, don't do this or don't do that, or do this and don't give somebody a reason why, or partner with them and really figuring it out, you know? So I love every bit of this conversation.
Yeah, just to piggyback what you said about the medications, mental health. Mental health is a lot of medications that we see some moms, depending on the medication, opt not to take them, or, you know, the doctor may say don't take it because, like you said, it's pregnancy. And then once they have that baby, you know, I say, oh, so are you going back on these medications? They are safe for breastfeeding, where it may not have been safe for whatever it was during a pregnancy. It is safe. And I like to share data with them. So if I am getting information from LactMed or Infant Risk Center, I'll talk about it, but I also like to print copies for them to share with their doctors, because ultimately, yes, it's the dynamic decision, but sometimes we not always inform on the latest research. So I kind of share that with them to share with their providers. So they can kind of feel a little bit more comfortable and advocate for themselves, saying, yes, it is safe for breastfeeding. Yes, I do want to get back on my medication, because we don't want mom to have, if it's depression, her to have more of a risk of postpartum depression if she's not on her medications.
Wow. And since we're talking about medication, one of the phrases that is commonly used inside of the hospital setting and even in the office setting, but more so the hospital setting, is this pump and dump concept, right? I know as a doctor, I cannot stand that phrase, pump and dump. And so like this conversation is crucial, not just for patients and families and communities. It's also crucial for healthcare providers, because I'll like, I don't know, have to go do a tubal ligation 6 weeks postpartum, and the anesthesiologist is like, oh, well, I guess she has to pump it. I mean, that's the perfect scenario, right? They come back for a laparoscopic self-injectomy, and they're nursing, and everybody from the person who enters their name into the system and admits them to the hospital, to the nursing staff in day hospital, to the anesthesia team that's checking her in, like all of those points of contact. And if there's that reinforcement of, you need to pump and dump, you need to pump and dump, it's really crucial that the education come from, bottom up, and that the team who's caring for these patients inside of the hospital know and understand what medications, which, by the way, as you said, Cheryl, are few that one would even have to pump and dump. If you have a healthy liver, your body is going to process medications long before it gets into breast milk. And so even some of the medications that are somewhat sedative or can lead to GI distress, those meds will leave your body long before they seep into your breast milk and impact your baby. So I think that, it's crucial that in this important conversation to point out terms like pump and dump, and it being what I consider to be a very useless phrase. And that's why I like Baby Friendly and the initiative that came out probably I don't know, maybe 10 years ago now, because what Baby Friendly does is it forces everyone inside the hospital, from cafeteria staff, environmental services staff, everybody at every level, jumps on board to support breastfeeding people and breast and chest feeding people. And I think it was a phenomenal thing to do to really standardize and systematize breastfeeding support.
Yeah. Not only do we see that pump and dump with the anesthesiology, but radiology too.
Oh,
mom
yeah.
would take a scan, and I remember a couple years ago, my mom was breastfeeding exclusively, and she had to get a scan, and she was told that she had to pump and dump. And, when, like you said, when everyone's saying the same thing, but then when you come in the room saying, no, you don't, they look like at you like you got 2 years, because majority of the people were saying, but you do. So then you got to show everyone so everyone knows that, no, this is the current data. We don't have to pump and dump. It is safe, So it's like, it's a culture learned, we got to learn it all over again, because there's research going to happen all the time on different things that we're going to re-educate ourselves on. But yeah.
Absolutely.
And, it's really, I think,
I'm sorry. We also hear the pump and dump thing when it comes to drinking alcohol and you're breastfeeding. And a lot of my friends, I breastfed my son for like 18 months. And a lot of my friends are like, oh, you can have a beer and still feed your baby. And so like learning that too, like Dr. Livingston said, like if you have a healthy liver, your body's going to metabolize that before your baby's next feed. So
yeah. Now, there's a recommendation on alcohol. The CDC says 1 standard drink is considered, safe if you're breastfeeding. You don't have to pump and dump. So what I normally tell moms is that. But then I also say, however, if you're going to be indulging into more than 1 standard drink, because, we're adults, we may go to wedding, whatever party, and we may be drinking more than 1 drink, if you have literally one drink and you breastfeed, it should leave your blood system, it should leave your breast milk within that 2 to 3 hours. But if you're drinking more than that standard drink, you got to double that time. So normally what I say, if you're away from your baby 4 hours, 5 hours, and you at this event and you drinking more than what's standard, you will want to still stimulate your breast. You always want to stimulate every 3 hours to make sure you're not dropping in your supply. So I normally say, if it's going to be a couple hours, so you're not going to be breastfeeding because you're still drinking, then you would want to pump, but you do want to dump that milk out because it's been more than one standard drink and you still feeling. If you still feeling tipsy 4 hours later, it's still in your body system. But no, if you're doing just the one standard drink, that is, you don't have to pump it up.
Are
Yeah.
there alternatives to just dumping your milk out, like dumping it down the drain? Like, can you use it for other stuff besides
Use it on-
feeding your baby?
yes. Yes,
Good
you could
question.
definitely
I
put
love
it
that
on your,
question.
yes,
Good.
definitely use it for the baby bath, skin, on your own skin. If you got a sore on your arm, it's like Neosporin. It's better than Neosporin. So yes, you can use it on your body, your skin.
I only asked because I was one of those moms that just put it into everything that he couldn't eat.
Yes, good.
Yeah, just on that, there's expensive kits and different things of, oh, I'm gonna measure it. Listen. And even, I think there's so much for safety. And I think that sometimes, just like how we've medicalized so many things about birth, that, sometimes we've kind of gotten really technical about breastfeeding. If you are like safe enough to hold your baby, like you can probably feed your baby, right? If you are safe to take care of your child and those things, I think, and I think one of the things we underestimate when we give people instructions is like how much like an impact it could have. So already if you're doing outpatient surgery, you're away from your child for a whole half of a day. And the stress, the anxiety, even like on the family, if you've got, like for who's caring for the baby while you're not there. And I just think sometimes we have to be mindful of how much these instructions that we give, whatever, even if it's like, oh, you need to make sure you're getting this much of this nutrient. I can think back to watching something about how stress affects a baby's like neurologic development, maternal stress affecting a baby's neurologic development. And I was like, I can't even control my stress. I'm just ruining my child. Like it can just be so, there's so many challenges that we can face. So I feel like one of the other things to convey is just like to give yourself grace. And so, you get the information, you've made the decision, we get the cheerleaders together to help support the decisions that we've made. And then we move forward. After all that commentary, I do have a question. What advice do you give about getting family support of breastfeeding? Yeah.
I was literally about to talk about support. Support is so needed, right? A lot of times when I hear mom who stopped, is either the pain or they didn't have help. And help can be anyone. Help can be a lactation. It can be a nurse. It can be a doula. It can be your baby daddy. It can be your mama. It takes a village, as they say, right? So it's definitely important to get support because it's hard. It is really hard. And breastfeeding is a full-time job. It is. It's lots of benefits to it, but it's hard. So you need your person with you to support you. A lot of dads say, I don't know how I can help. I can't breastfeed. No, there's a lot of things you can do. You can help get mom comfortable in the chair. Her pillows. A lot of time moms breastfeeding, you grab the baby and they just start breastfeeding. You want to position yourself comfortable first. And a lot of times they think about the baby. Dad can help mom get comfortable in a chair. Dad can have water on the bedside. Dad can have crackers on the bedside. Dad can change diapers. So, so that way mom is not just the sole provider. She's the sole feeding right now, but she doesn't have to be the sole caretaker. She can have help and support from other people, the support person, dads, doulas to change diapers, meal prep, helping with siblings, because she will need that support in order to be successful.
Wow, I love that you
Yes.
yeah, I love, right, Sabrina? I like that you
I feel
pinpointed on that. Kimberly Seals Allers talked about that, and that was one of her 5 bullet points that she said 5 reasons why we need Black Breastfeeding Week. And the 5th one was where she said many African-American communities are what they call first food deserts. And the reason she called them first food deserts was because of the lack of community support. And it doesn't mean that the people in these communities are bad. It means that the resources or the lack of resources in these communities was so profound that it made, as you said, Cheryl, breastfeeding a challenge. I was talking with a colleague today, and they were talking about all of these social determinants of health playing such a magnanimous role on health outcomes. So you're exactly right. Like, I think it's important to focus on the fact that many African American communities are first food deserts. And we are here tonight to really pinpoint the reality that there is a disparity, because we have to acknowledge first, right? And propose solutions like getting people like you out there front and center, letting the community know that you're out there, and increasing access so that Black and brown breastfeeding people and chest feeding people have access to people like you. So, we don't want any more deserts. That's the whole point, that we're here tonight to just continue to eliminate and eradicate the pockets of disparity that exist way too often in our communities.
Yeah. And I also think that a lot of Black moms, we're comfortable with our own, right? We always comfortable, right? And I think that when you go into these moms' home, they feel initially hesitant, especially if you're not Black or brown, they feel like they may be judged, and they don't want no one coming in their home. So then they feel like, okay, never mind, I figure out myself. So then they don't utilize that support, but when you find someone, I have someone told me, oh my God, I've been looking for someone like you, So when you find someone like me, or a brown Latino, or anyone who kind of, they have shared experience, they can connect with each other, and they be able to support them differently, we kind of become like a family, So it makes it more relaxed for that mom to open up and share, and and willing to allow you to help them. Yeah.
That
Wow.
Baltimore accent
That's
keeps
my
coming
Baltimore
out. I'm tripping. I am tripping. I love it.
I love
Nikki, you from
this.
Baltimore too, right? Is it Baltimore or Maryland, though? Because Baltimore got the
Yeah,
accent.
no, I'm from Baltimore, and I get the whole.
I
get
hear
it.
it.
Yeah, exactly. It sounds normal to me. Doesn't everybody talk like this? Like,
Get it,
I
y'all.
don't think.
Get it. Get it.
Oh my goodness, Cheryl, I'm wondering if you can talk about the setup. So you mentioned a little bit about, dad helping the mom get comfortable in a chair, but when I think about like the social, what's the expectation, people coming to visit. So I know we have some doulas on, just kind of like, how can we help people to be set up for success as far as what I call the environmental factors, meaning the people around, just some of those things, if in your experience, and I can share some of mine.
Yeah. Some moms are comfortable and they don't care if anyone else is around. And some moms, even in that immediate postpartum period in the hospital, you can be exposed like, they be like, oh, I don't care. So some moms don't care, they exposed, and some moms are still modest. So, I say about, the covers, the breastfeeding cover-ups they can use if they breastfeeding in front of family. You can ask the family to leave because you're feeding your baby. It's okay. You're not going to hurt their feelings. And if they want to go to another room, they can go into another room. But they just need to understand, because I know a lot of moms will say, well, I'll feed a baby after everyone leaves. Your baby can't wait. Your baby wants, you eat when you're ready. Your baby has to eat. We can't postpone their feeding time because a family is in the house. If they're uncomfortable, and maybe dad can speak up. Sometimes dad can speak, okay, my girlfriend is trying to feed a baby. Y'all got to go, so that way she can feel comfortable.
Wow.
Yeah, absolutely. I feel like, even as we're like in the hospital postpartum rounding, or for doulas, if you're visiting with a patient who's recently delivered, I feel like we can be such a great help with just like air traffic control. When a person has said, hey, this is what I want to do. I want to do immediate skin to skin. I want to try to get the baby to latch. All of that stuff, even if it's to speak up to say, hey, have we done the skin to skin before we go and get the weight? Many hospitals are doing that now. It's like, oh, they're gonna have an hour of skin to skin. Well, you have people calling and texting, how much does the baby weigh? Send me pictures, all this stuff to kind of get everybody back again, focused on that mom and baby unit can be so helpful. And then when you go home, everybody want to come and breathe all over your child. I'm like, we learned all about germs, right? It's not over. Like, can y'all leave this newborn baby alone? And, and if you are coming for something, maybe perhaps it's some of that, giving that guidance. I think a lot of times we're so used to like not wanting to, like, I don't know if it's not wanting to ask people for things, but I think that giving people that permission again, like, hey, people want to help you. Coming by and looking at you is not helpful. They can bring you a meal. Oh, did you have a meal for Thursday already? Did your sister already get this set up for the meals for the different days, things that are, freezer safe or whatever? And like somebody coming to pick up, your older child to go and give them some time. But I think all of those things are such beautiful gifts that we can give to, our families that we're supporting. And sometimes it's like your sister, your girlfriend, or somebody in your family or somebody that you're serving in a formal role.
Yeah. I tell
Wow.
moms all the time, speak up. We have to advocate for ourselves. It's okay to say, no, I'm come back in like 3 weeks, or I always tell them the same thing. If you're going to come, make sure they bring something to eat. Make sure they prepare to wash some dishes. But you're not just coming to see the baby. I need support. I need help in this time right now.
I love that you said that. I want to make two points. One, in the hospital, we always say the wait can wait. I love that. Like, it's just like the mom and baby and the family and baby deserve that time to bond. And so, the wait really can wait. I heard of a very effective trick that works when people are coming to visit, especially in families of color, because we do typically, I know I'm stereotyping, have very strong personalities and people want to help. But it's great to have a list that says something like, if you're coming to visit, we're happy you're here, but here are the things that you can do to help me and baby continue to bond. Put a load of clothes in the wash, or take it out, help fold clothes, wash dishes, because it's so important that the core family unit have time to bond and, have what we call that golden hour, that golden time. And the less chaotic the house is, the more peaceful the environment, and the more peaceful the environment, it just makes it a better family unit, for mom, baby, and other support person and baby. So it's little tricks like that, because if you put up a list, it takes it away. You don't have the responsibility of saying it out of your mouth. You can, people walk in your house, they see your little list of, while baby and I bond, here are things that you can help with.
Yeah. You mentioned the golden hour. I just want to say something about that.
Mhm.
And a lot of baby friendly hospitals, and even hospitals not baby friendly, but more baby friendly, are definitely utilizing that wait until weigh the baby and doing that skin to skin, because that golden hour is the perfect time for the baby to breastfeed. They are so alert in that golden hour. They are, ready to feed. It helps long-term duration breastfeeding rates. And then they get really sleepy after that in that first 24 hours. So I always tell mom, make sure you feed in that time frame, because that is literally the perfect time to feed your baby. And that's when you get lots of antibodies. That colostrum that the baby gets first on is filled with antibodies, and it's really, really beneficial for your baby. Those antibodies, like your baby first immunization before they get their hepatitis B vaccine or the other vaccines.
Mm-hmm. Mm-hmm.
I love that. And I think it does something for like when you're in that room and before anybody has done anything, and that baby just kind of creeps up the body and finds the breast, and there got a good latch. It's like in Twilight, when they imprinted, and it's like, because what happens for the mom, like you can just see the confidence of like, oh, I'm able to do this, and I think it's just one of those most beautiful things. So it's like how we can set the scene, set the stage, and kind of help things along. Thank you for that.
So true. Sabrina.
Yes, I'm nodding my head because I like what she said, that imprint, like it really does feel like that.
I
Like
love that.
I had that experience with my son and it's so beautiful. And even though that moment is so natural, breastfeeding really does come with some technique to it. And that's something I wanted you to go into a little bit. Like as much as people want it to seem like, oh, your baby's just gonna get on the boob and do the thing. But there, no, like I had some trouble in the first few weeks and I had my first 2 weeks, I would say, were really hard. My nipples were bleeding and everything. So I reached out to an IBCLC and literally off her first visit, no pain. Like and I was afraid to try different positions. I didn't even know. I mean, I kind of knew there was different positions, but I was afraid to try them by myself. So if you
Yeah.
can kind of go into that.
Yep. You know, the positions that we recommend in those immediate postpartum period is cross cradle and football. And I'm gonna demonstrate it with my doll. But a lot of times when we go breastfeed, we hold a baby naturally in a cradle hold. Y'all guys see me? So we
Mhm.
naturally hold a baby in a cradle hold. When baby in this position, they don't have that full head control yet. It's really hard for them to grasp the nipple and sustain that latch. So we do recommend supporting the baby and breast more, and the football or cross cradle position does that. So when I'm doing the cross cradle position, I'm trying to bring my laptop there so you guys can see it. Can you see?
Mhm.
Yes.
When I'm doing a cross cradle position, I'm going to turn my baby belly to belly. So now my baby is facing my breast and is facing the food. And then I'm going to support my breast. See, I'm sorry, I'm trying to angle it. Sorry, guys. Okay. So I'm going to angle my breast in front of the baby mouth to kind of get that asymmetrical latch. But I'm holding my breast and I'm holding the baby during that time frame because the baby can't let, they have that control right away. And the other good one is football, especially if a mom had a C-section or if she has larger breasts. The football position is really good as well. So kind of hold the baby on the side of the breast. Guys see that? So I'm supporting
Yep.
the baby nape of the neck, and I'm holding the baby at the breast, and then kind of gotta latch the baby that way. Okay. But I'm
That's
holding my breast in a sandwich shape, and I'm supporting my baby's neck.
that's the position I did that relieved so much pain, and yeah, they're really helpful.
Mhm.
Can you sew the sandwich again?
Yeah, section of my breast. So I kind of like a C shape on your breast, or you can also do like a U shape as well, depending on the position.
Mhm.
Once you're more comfortable, a couple weeks later, the sideline is really good. The laid back position is really good. But when baby's really learning in that immediate postpartum period, cross cradle and football are the two that I recommend.
What if somebody works in a job that is not supportive for pumping? What do you recommend? Because for marginalized people, that's a real issue.
Yeah. So by law, they're supposed to get a safe place to pump, by law. If they have if a job has 50 or more employees by law, they supposedly have breaks for pumping and they're supposed to have a place to pump at. Can't say everywhere is doing that because they're not. And of course, you can bring it up to HR, but then they're concerned about their job. And no, a bathroom is not a safe place to pump at all. And it's dirty. And no, they're supposed to provide us a place to pump. A lot of moms say they can't, they don't have it. I don't know what to do. I say bring it up to your supervisor, bring it up to your HR, because it's literally is a law and they're supposed to provide a space. They do have those wearable breast pumps now.
Oh
So that way they
yeah.
can pump.
Yeah.
All the insurances though are not covering the wearable pumps 100%. There are a few insurance companies that are, but not all of them. But it is another alternative to moms who are working so they don't have to take quote unquote breaks. They'll put their wearable pumps in, but you are entitled to pumping breaks. Just like they go out and have smoke breaks, you're entitled to pump breaks.
Right? There was no problem there. Some smoke breaks. That's so true.
And then, so when pumping at work, what do you recommend? How long? How often?
Mhm. So your body should be stimulating every 3, no longer than 4 hours. So if you're working an 8-hour shift or a 12-hour shift, you want to pump at least every 3 to 4 hours. Normally, I tell my mom when she's going back to work and we develop a plan, I'll say, okay, do a breastfeeding right before you go to work. You know, that's your breastfeeding section, say at 7 o'clock, because you got to be at work, I don't know, 8:30. So then that way you're going to have a pumping section around 10:30, 11 o'clock. And then you can have another one around 2-ish. And then you're getting off probably at 4 o'clock. And when you get home, you're breastfeeding your baby. So you're looking at 2 pumping sessions if you're working like an 8-hour shift, and maybe like a 3 pump section if you're working a 12-hour shift. But you want to try to at least stimulate every 3, no later than 4 hours. And it's hard, especially if you're working and busy. I can tell you in healthcare, it's hard to try to take breaks when you're taking care of patients. To pump. So a lot of our colleagues do have those wearable breast pumps.
Mm-hmm.
Even though we do have pumping rooms, it's just one of those things where sometimes you're just so busy and you can't get away. So you just, but your body going to tell you if it's time, because you're going to start to get engorged and breast going to be leaking and you're going to be feeling uncomfortable until you get that milk out.
Yeah.
Wow. I'm an OBGYN and I'm learning so much from you. Like I could listen to you just on and on. I can't even imagine how much great information you're getting across to community members and families and patients. So any more questions, Sabrina, before we close up the house?
I could probably continue for another hour. I'm not even,
Right,
I
right.
love breastfeed, all things breastfeeding and stuff. I'm super passionate about it. I'm so grateful we could have you with us with DDI and PRW, Cheryl. We really appreciate it.
Thank you. You know,
Yeah.
when I had my youngest, my daughter, she's 18 now. I didn't have much support at the hospital. I think now it's more support than it was then. It was the stigma of we're not going to breastfeed, so why bother? And I feel like, I mean, that's from the staff. You know, I feel like, and you didn't have much support, and I felt like I was home trying to figure out why. And I was not a postpartum nurse then. I was a med surg. I started as a med surg nurse. So, and I was the only person in my family who breastfed. I was the first breastfeeder in my family. So I didn't have support to go to say, okay, what's going on? Why am I in pain? Why my nip was cracking and why is my bleeding? You know, I had to educate myself. But it's sad because I still hear sometimes, well, I didn't have help. No one came to really help me. Or they kept saying, keep trying, you'll get it. Sometimes you really need to be hands-on and really show that mom how to latch the baby. Sometimes we talk about it, but some people are not just learn that way. You actually got to demonstrate and be hands-on for them to grasp the education.
Wow. And, you know, speaking of education, you know, Patients Are Waiting is an organization that is not afraid to center Black people. We are very intentional about what and who we want to serve and bring to the center. Marginalized people, obviously Black people, Black birthing people, Black students. It's just our mantra. It's what we do. And Black Breastfeeding Week was yet another opportunity for us to really highlight disparities that exist amongst breastfeeding people and chest feeding people. And so we were not going to miss this opportunity to highlight the importance of increasing the rates of breastfeeding and chest feeding in the Black community, because we know it helps decrease infant mortality. It helps address issues like hypertension and diabetes. It helps bring front and center the fact that our breasts are not just for entertainment or pleasure purposes, but our breasts were made for feeding our babies. And addressing the issues that exist in our community surrounding breastfeeding support. So we were not going to miss out, and we still won't miss out on the opportunity to highlight humans like you, Cheryl, to bring front and center the wonderful doulas that we have in our catchment and support y'all. Like I said, our third area of focus is supporting minority clinicians in practice. Dr. Hamblin and I mean it when we say we cast a wide net when we make that statement. It is not just casting the net for doctors or casting the net for midwives. It is understanding the importance of who and what makes a great perinatal workforce. And so we support our doulas, we support our team members like our IBCLC colleague that we have in you, Cheryl. We are doing so much for the rest of this week. Tomorrow, my house is going to be, you know, the cookie house. Everybody's coming over here tomorrow to bake lactation cookies. Wednesday, we're dawning upon the Capitol and talking with some really amazing people in the Pennsylvania State Legislature, Department of Health, to really center the voices of doulas to help with the maternal health strategic plan here in Pennsylvania. People are listening to us, and they are listening to us because we have a message, we have solutions, we are intentional, and we are going to get this done so that we can continue to make birth safe, but not just birth, but make everything regarding health disparities better and improve those things. So, and then Thursday, we're having an open house at the Black Doctor Factory. Friday, we're having a flow donation drive. And if you bring menstrual hygiene products, you get lactation cookies that are being baked earlier in the week. So we value you, Cheryl, and we are happy that you are a friend of Patients Are Waiting. And I suspect that this will not be the last time that we're going to be leaning on you to educate us.
Thank you for having me. I just want to say one thing to Dr. Livingston. When I first met her, she was my doctor, and I was trying to find a Black provider. You know, I'm from Baltimore, so it's not that many when you move around here, you know, so I was trying to find a Black OBGYN, and I found her, and I said, oh, she is nice, and she's thorough. And I say thorough, and she listened. That's the really important thing. Like, you know, our patients say, oh, they didn't hear me, they didn't listen to me. She listens, and she truly, truly, truly care about her patient. I'm talking from a patient perspective. She truly care about her patients, and she truly want to make sure you're living a healthy life. And when I met her, I'm like, oh my God, I just love this doctor. And then moving forward, you was doing this initiative, and I'm so awesome that you're trying to, you know, provide this awareness and support Black and brown families, because it's needed. And so I just want to thank you too, and thanks for all you do.
Oh, thanks, Cheryl. We all care a lot about you. We appreciate you.
Okay. Thank you guys for joining.
Thank you for joining. We were so happy that you were able to join us. Any final questions before we say goodnight? No? All
Even
right.
if it's not a question, sorry. For the doulas on, if you would just say hi, where you are, and if, you know, anything you have to say to Cheryl. Thank you so much.
I'll start off with hello, this is Blessing. I live in Lancaster, PA. I became a certified prenatal and postpartum doula in April, May of this year. And I just want to say thank you very much for sharing this information with us, because it's really very helpful. I currently have a mom who's due in any moment right now. And I know that I'll be sharing this video with her, and it's going to be very informative for her as well. So thank you very much for this.
You're welcome. Good luck with her delivery.
Yeah, keeping fingers crossed all goes well. I know it will.
Aw, blessing. Nikki, Ranisha.
My cat jumping around.
Oh, hi, I'm Renisha, but I go by Nisha, so that I think that's why Cheryl called me Nisha. Somebody called me Nisha. I'm in Lancaster. I'm currently cooking for my kids. One started kindergarten and one started 6th grade.
Oh.
I'm also a certified doula. I completed the course with Blessing. I do have a client that I was hoping she would join, but she wasn't able to. So I will be taking all this information back to her. And I thank you so much, Cheryl.
You're welcome. Thank you.
Courtney.
Hello, everybody. I just walked in the door from 3 hours of birth planning after about 8, 9 hours of work. So I am exhausted. But my name is Courtney Jordan Cox. I became a doula at the same time as Blessing. through Patients Are Waiting, Diversifying Doula Initiative. And I right now have 2 clients with a possible third. This is really great information because we're just now, because I'm dealing with one mother who's just at the very end, and we're about to start having less conversations, hopefully about birth and more about what's going to happen with breastfeeding and postpartum. So this conversation is right on time. I'm also super excited to see whoever's going to be at the Capitol on Wednesday. I'm really thrilled to be there with you all. And I appreciate, even though I've only been on for like 20 minutes, I am so appreciative of this information and so glad to be here.
Thank you.
I'm gonna go ahead. Hey, I'm Jasmine. I got certified as a birth doula through National Black Doulas Association. I have been a doula for about 1.5 years. But this conversation was really enlightening, and it also helped answer some questions that I currently have now with a couple of families that I'm supporting. So I'm very thankful for this conversation, and I thank you.
You're welcome.
I'm Nikki. I was certified doula with the last DDI cohort with Courtney and Blessing and Renisha. I live in Shrewsbury, Pennsylvania, originally from Baltimore. I am just starting with my first client now. So and thank you
Congratulations.
for all the great information.
Well, congratulations.
Thank you,
Oh,
ladies, for introducing yourselves. I was also a part of this cohort, so I'm a certified doula right along with these last couple ladies that have introduced themselves. And again, thank you so much, Cheryl, and we really, really appreciate this conversation. And we will tag you in anything and everything we post in regards to today's Zoom.
Thank you.
Can I
Thanks,
ask a
y'all.
quick question? Where will we find the recording?
I can send it to you, Courtney.
That's great, because I gotta go back and listen from the beginning. I only got the end.
Yes, you
Girl,
do.
it was good. Cheryl
Thank you.
brought it home. She taught a lot. We loved it.
Thank you.
Yeah.
Yeah,
I'll
we'll
send
share
to
it,
all
Courtney.
the doulas. Yeah.
Yep. All right, y'all. Good night.
Thanks, guys. Take
Thank
care.
you so much. Take
Thank
care. Enjoy your
you.
evening.
Bye.
Night.
Bye.
Good night.